aphasia negatively impacts on social functioning, psychological well-being and quality of life. Aphasia is associated with increased mortality, a greater need for health services and more disability. Aphasia and a personal history of mental health illness or family history of mental health are risk factors for serious psychological and mental health conditions after stroke. And we also know that people with aphasia have higher levels of distress compared to their non-aphasic peers. And we also know that depression is common after stroke. Approximately 1/3 of the population will have it. And there's a very high incidence for our subpopulation of people with aphasia. And in one study, major depression increased across the first year post-stroke from 11% to 33%. Of major concern is the current lack of psychological care after stroke to match this need. So our Australian stroke outcome audits show that there's a lack of assessment in the first place, and then there's also a lack of counselling offered to stroke patients and for people with aphasia with a communication barrier, it's difficult for them to access those conventional psychological assessments and interventions that really rely on the understanding and production of speech. So, is stepped psychological care after stroke the answer? And if so, how can we deliver it for people with aphasia who have the communication disability? So what is stepped psychological care? It's a multidisciplinary framework. All people with aphasia enter level 1 for mood screening and some psychological information provision. And those with a normal response and sub-threshold symptoms stay there at level 1 for some basic interventions. And this can be delivered by a range of trained health professionals. But for those who present with mild through to severe mood impairment, they're triaged up to levels 2, 3 or 4, depending on the severity of their symptoms and the need, the level of intensity required to treat their depression. So clinical psychologists and mental health specialists can provide intervention at these higher levels of care. The overarching aim of this research was to investigate what the evidence practice gap is in managing mood change and depression for people with aphasia after stroke. And we wanted to know, is stepped psychological care a solution to closing this gap? To achieve the aim, we designed 3 studies. The first was a systematic review to identify rehabilitation interventions that could be included in levels 1 to 4 of stepped psychological care. And studies 2 and 3 were qualitative studies to investigate the perspectives of stroke health professionals and people with aphasia regarding current practice and their experiences. Study 1, the systematic review, has been published in Disability and Rehabilitation, and you're very welcome to have a read of that for some more details on what can help enhance mood. Study 2 aimed to describe current practice and the barriers and facilitators to stepped psychological care, and Study 3 aimed to describe the experiences and preferences of people with aphasia. So with the stroke teams, we conducted 5 focus groups within regional and metropolitan health networks. 39 participants represented a range of disciplines across acute, rehabilitation and community settings. And these included allied health, nursing and medical professions. In Study 3, we conducted 20 interviews with 10 participants with aphasia. They ranged in severity of communication and mood problems, and they lived in metropolitan and regional areas of Australia, and they were at different phases of rehabilitation post-stroke. Interpretive description guided the method and data analysis. Transcripts were coded and core themes and sub-themes were derived within studies 2 and 3. And I'll now describe the evidence practice gap for you through an overview and comparison of these studies. So in study 1, we described the need for routine assessment for people with aphasia and the provision of psychological information. And we also identified a number of communication and psychosocial therapies that may enhance mood within level 1. And these are presented here in the blue font. However, in contrast, core themes derived from study 2, presented to the left of this slide, describe that actual clinical practice is inconsistent with mixed approaches to mood screening. There is infrequent use of aphasia-specific mood measures. And in alignment with this, people with aphasia reported that health professionals do not always understand their history and communication needs to effectively assess low mood and depression. They aren't provided with the time and the strategies to communicate how they are really feeling. Study 1 identified psychological therapies that may be effective for those with mild depression, and these are highlighted here in green. The strongest evidence for reducing depressive symptoms for people with aphasia is behavioural therapy, and this is through increasing the frequency of enjoyable activities that are chosen by the person. However, again, in contrast, it was clear that stroke teams are trying to support mood, but availability and access to psychological therapies are limited, and antidepressant medication trials are more common with monitoring of progress and side effects. This lack of psychological care is concerning when people with aphasia describe the onset of stroke and aphasia as a traumatic event. Many describe negative experiences such as feeling imprisoned, hopeless, lonely and scared, and they are not always being supported to communicate, be independent or make decisions about stroke rehabilitation, which further impacts on mood. And at levels 3 and 4, study 1 highlighted that more research is needed to know how we can help people with severe mood problems after aphasia. Certainly collaboration with mental health specialists and one-to-one approaches are essential. And at these higher levels, stroke health professionals are seeking internal and external supports, and they're also describing how difficult it is to engage people with significant aphasia and depression in stroke rehab. And in alignment, people with aphasia described the difficulty in engaging in stroke rehab and social activities. A few of the participants had quite severe depression and described it as a scary and dark sort of place. Regarding STEP psychological care, the perspectives of stroke health professionals in terms of barriers were a lack of skills and knowledge, a lack of physical space to support psychological care, and a lack of resources and leadership and research in this area. But people with aphasia were really clear in what they wanted and needed. They needed positivity throughout their rehabilitation. They definitely needed communication support, and they wanted access to individually tailored therapy that was encompassing of their strengths and interests. So this model conceptualises some possible solutions. The person with aphasia is at the centre of STEP psychological care, and we can accommodate their preferences, perhaps through some interdisciplinary joint sessions, so sharing therapy sessions between speech pathology, clinical psychology and other team members. The stroke health professionals require 3 major areas of need, which are presented in those boxed arrows. They require training and information about communication support and managing mood problems. They require strong clinical and health management leadership, and resources and appropriate physical spaces to support social participation and the privacy required for counselling and quiet reflection time. So STEP Psychological Care offers a solution to closing the evidence practice gap. We have the evidence and now action is required to implement some of these changes to stroke and aphasia rehabilitation. More research is required to find effective psychosocial therapies to directly target mood outcomes. And we also need to engage policymakers to develop new processes and allocate resources to evaluate these interventions. So thank you for your attention.
Thank you, Caroline. Do we have a question for Caroline?
Thank you so much, Caroline, and I want to commend you on that systematic review because I've read it about probably 150 times and it's truly excellent. So
thank you.
Thank you so much for publishing and doing that piece of work. It's kind of two things in this question. One is about reaction versus prevention with mood, and kind of the other thing is, in your paper you said that those that deny the initial consequences of stroke as a traumatic event have longer term disability and mood difficulties. So the timing of this as well, is this something that we need to be looking at on the day or when someone has a stroke, and how they can understand that, comprehend it and manage it? Because we know in other literature that does help people to actually feel well and maintain that connection to feeling well. Yeah, so
Definitely.
Two things, prevention and timing.
Yes, it's a fantastic point you've made, Kira, thank you. It's really important that we're proactive and onto this early, sort of immediately post-stroke. People are coming through our hospitals and we're not even identifying that a person might have had a past history of mental health problems as well. And it's not until they're getting home that things are falling apart. So if we can put in place some systems to identify that there's a problem in the first place and to acknowledge that, and then get on to some management in talking with the medical team, highlighting it to the rest of the team, really raising it in our case conferences and team discussions, and liaising with our GPs as well once people are in the community, because the people I spoke to really, things started to fall apart once they were getting home and trying to resume their lives again and relationships. Yeah, and yeah, so prevention, is very important. It's something we're looking at. In the systematic review, we didn't find any evidence to say what prevents depression for people with aphasia, but certainly the aspects of social participation, our relationships, are really important, and working in with the team too to find out what might be helpful in terms of medical management too.
Great. Thank you, Caroline.